All right, thank you very much, Dana, for getting us started, and welcome everyone. Thank you for being with us today. My name is Katy McKee. Erin and I work out of the Pennsylvania Health Law Project's Pittsburgh office, and we are very pleased to be with you today to talk about Medicare in 2023. As Dana said, please feel free to put your questions in the Q&A as we go along. We're going to be covering a lot of material today, and we will stop and take questions at the end of each section as we go. So just briefly, in case you aren't familiar with our program, the Pennsylvania Health Law Project is a free legal services office. We provide statewide services across Pennsylvania. Folks can call us if they have questions about Medicaid, access to Medicaid coverage and services. We work with a lot of folks who are dual eligible for both Medicare and Medicaid, so low income Medicare beneficiaries, which is really going to be the focus of our presentation today. We have a helpline that's open Mondays and Wednesdays. Folks can call in from 8 a.m. to 8 p.m. on Mondays and Wednesdays. You can also email us to contact our helpline. We have tons of really good resources on our website about many of the programs we're going to talk about today, as well as other Medicaid programs. We have a monthly newsletter, which we hope you'll join. And part of what we do in addition to helping people directly is systemic advocacy. So we take the information that we gain from working with clients and advocate with the state to make the Medicaid program even better. So just, folks can call us if they are denied or terminated from Medicaid, if they need help understanding how their Medicaid and Medicare work together, if they're having problems getting medications at the pharmacy, or if they're seeking information about the programs we're going to talk about today that help with Medicare costs, or if they're having trouble getting access to services through their Community Health Choices Medicaid plan, their Health Choices Medicaid plan. We help people get those services. We don't have any income limits. Anyone can call us, people who are Medicaid beneficiaries, social workers, medical professionals, family members who are looking for information. So please feel free to reach out to our office if you need help. So today, I just want to give you a quick roadmap of what we're going to be going over. We're going to start by covering some Medicare basics, just to make sure we're all on the same page as we get started. And then we'll get into some of the Medicare updates for 2023. We'll talk about programs that help with Medicare costs. We'll talk a bit about dual eligibility, how Medicare and Medicaid can work together. And then as we're still in the COVID public health emergency and, expect that will end someday, we'll talk a little bit about preparations for public health emergency unwinding. So to get started, we wanted to launch a quick poll just to see kind of what everyone's Medicaid comfort level or Medicare comfort level is to get started. So hopefully you see the poll up on your screen. If you can give us a sense of your level of Medicare knowledge, we'd appreciate it. So thanks for responding to that. All right, so let's get started by just briefly going over Medicare basics. I know it looks like many of you have kind of an intermediate level of Medicare knowledge. Please feel free to tune out. If some of this stuff is too basic for you, it might be a good time to refill your coffee. But we're going to go over the parts of Medicare. So just to give you a sense of the scope of the Medicare program, enrollment data from 2022 tells us that 64.5 million people are covered by Medicare. This is a huge federal health insurance program. In Pennsylvania, more than 2.8 million people are covered by Medicare in Pennsylvania. Social Security handles the eligibility and for Medicare and enrollment in Medicare Parts A and B. And it's also the agency through which people can apply for extra help, which is with their prescription drug costs, which is one of the programs we'll talk about a little later. The Center for Medicare and Medicaid Services, or CMS, oversees and administers the Medicare program, handles enrollment in Medicare Advantage and Part D prescription drug plans, and also oversees the Extra Help program. So just briefly, we wanted to mention who gets Medicare. So folks are eligible for Medicare when they turn 65, or if they have been receiving Social Security disability benefits for 2 years, or if they have end-stage renal disease and are receiving dialysis or have had a kidney transplant. So that's the group of folks who can access Medicare coverage. Enrollment is automatic if someone is getting Social Security benefits at 65, or if they've been receiving those Social Security disability benefits for 2 years. But for other folks, people have to actively enroll. So many people now don't start receiving their Social Security benefits until after age 65. Those folks are going to need to contact Social Security and make sure to actively enroll in Medicare. And it's important to do that timely, right? Because with Medicare, enrollment periods apply. You get an initial enrollment period when you turn 65. If you don't enroll when you're first eligible, you could potentially have a gap in coverage. You might be subject to a late enrollment penalty. So it's important to enroll in Medicare when you are first eligible. And we've got links in our materials to the enrollment rules for the different parts of Medicare and the special rules for folks who have end-stage renal disease. If someone is known to Medicare when they become known to Social Security when they become Medicare eligible, they get a welcome to Medicare packet. They get their red, white, and blue Medicare card. And we know that if somebody has end-stage renal disease, the social workers at the dialysis clinic or the transplant social workers help them take care of enrollment into Medicare. Okay, so let's briefly go over the parts of Medicare. Like I mentioned, when you go on Medicare, you get a red, white, and blue Medicare card in the mail. It shows your Part A and Part B start dates. Part A of Medicare is Medicare's hospital insurance piece. So it generally covers the care that people get in a facility. So Part A of Medicare provides coverage for hospital stays and also short-term stays in a skilled nursing facility or rehab facility up to 100 days potentially. It also covers home health benefits after a qualifying hospital stay, hospice care. There's a deductible, and there are copays after a certain number of days in a nursing home or in the hospital. Medicare Part B is the outpatient coverage section of Medicare. There's an annual deductible and a monthly premium. This year in 2022, the monthly premium is $170.10. We all recently got the good news that starting in 2023, the Part B premium is going to be going down a little bit, which is nice for Medicare beneficiaries. Folks' Part B premium typically comes out of their Social Security check. With Medicare Part B, if you don't enroll when you're first eligible, you may be subject to a late enrollment penalty if you need to enroll later. Part B, if you use original Medicare and the red, white, and blue Medicare card, Part B covers 80% of most services. The beneficiary is responsible for 20% coinsurance. And then there are some preventative services that are covered up to 100%. But your Medicare Part B is what's covering your typical doctor's visits, x-rays, tests, medical equipment, stuff like that that you might need. So Medicare Part C is Medicare Advantage. This is not a different benefit. It's just a different way for people to get Medicare Part A and B, and usually Part D coverage as well. through a private insurance company. So you can choose, and we'll talk about this a little bit, to either get your Medicare coverage just through original Medicare and you use your red, white, and blue Medicare card when you go to the doctor or hospital, or folks can choose to enroll in a private Medicare Advantage plan. Medicare Advantage plans can offer extra benefits. Medicare doesn't cover things like dental care, vision, but often Medicare Advantage plans offer some of those kind of extra benefits, a certain amount of credit towards dental care, a pair of glasses, and a vision screening. If you choose to enroll in a Medicare Advantage plan, then you're subject to the plan's network and plan rules. You still have to pay your Part B premium. Often we'll see ads for Medicare Advantage that says, no, there's zero premium. That's no extra premium. You still have to pay your Medicare Part B premium. Everyone is responsible for that. And they often have a different cost structure than just original Medicare. So people have copays maybe instead of co-insurance. The health plans that are in the Medicare Advantage arena are approved by Medicare, and there are often dozens of these plans available, depending on the county you live in. And I'm sure everyone is seeing the TV ads and the billboards, and Medicare beneficiaries are getting lots of mailings from these companies right now. Medicare Part D is D for drug is Medicare's prescription drug benefit. If you have original Medicare, you need to enroll in a separate prescription drug plan for your prescription drug coverage. You pay a monthly premium. There are typically copays for medications. If you don't enroll timely and don't have other prescription drug coverage, you can also be subject to a late enrollment penalty. Most Medicare Advantage plans include Part D coverage, but not all of them do. So it's important that if you're selecting a Medicare Advantage plan instead of original Medicare and a Part D plan, that you're aware of the benefits and know if it includes prescription drug coverage. So just stepping back, as I mentioned, people have choices about how they get their Medicare. These are sort of the two ways that people can choose to get their Medicare. They can have original Medicare through their red, white, and blue Medicare card, Parts A and B, add on a prescription drug plan, and then they can also add supplemental coverage. We'll talk a little bit about Medigaps, which are Medicare supplemental insurance plans that work with original Medicare. Or people can choose to enroll in a Medicare Advantage plan. So there's been a lot of growth in Medicare Advantage. Right now in 2022, 48% of the Medicare population is enrolled in a Medicare Advantage plan versus 52% in original Medicare. That percentage is even higher in Pennsylvania. In Pennsylvania, 52% of Medicare beneficiaries are enrolled in a Medicare Advantage plan. And it's particularly high where Erin and I are here in Western Pennsylvania. For example, in Allegheny County, 72% of Medicare beneficiaries are enrolled in a Medicare Advantage plan. We just wanted to highlight this because, there's been a lot of growth, but recent studies and reports have highlighted some problems with Medicare Advantage as well. There was a recent New York Times article that talked about Medicare Advantage plans that have been accused of fraud and overbilling. The extra benefits that can come with Medicare Advantage plans are often really enticing to folks, but enrolling in a Medicare Advantage plan also comes with being limited to a network, being subject to the plan's prior authorization requirements and other rules. So we just wanted to share this so that people are mindful about it, that folks have choices. There's a whole lot of marketing that goes on of Medicare Advantage plans. And a lot of people feel more comfortable being enrolled in a private insurance plan because that's what they're used to, maybe if they had employer coverage. And so it can be very appealing, but there are considerations when people are making a decision about whether to enroll in original Medicare or in a Medicare Advantage plan. So right now we're in the middle of the annual open enrollment period, which runs until December 7th. So this is the time when Medicare beneficiaries have an opportunity to review their Medicare coverage and potentially make a change to it. They may be enrolled in a Medicare Advantage plan or a Part D prescription drug plan that they've been happy with, but each year those plans can change. The networks can change, the formulary for Part D prescription drug plans can change. So it's really important that everyone review their current coverage and make sure it will continue to meet their needs in the new year. If people make enrollment changes during the annual open enrollment period, those changes are effective January 1st. And it's worth talking a little bit about when somebody is considering whether their current Medicare coverage will continue to make sense for them. You want to make sure that your doctors and other health providers will continue to take your plan, check the rules for coverage of the care that you need, make sure that your preferred pharmacy takes your plan, and that your prescription drugs are covered. So it's just a nice opportunity to sit down and review your coverage, and resources like Pennsylvania's SHIP program, the PA Medi program, are available to help people review their plan options. So since we're talking about open enrollment, we thought this was a good time to remind you a little bit about other Medicare enrollment periods. So right now we're in the annual open enrollment period in the fall, but there's also a Medicare Advantage open enrollment period in January 1st through March 31st, which allows people in Medicare Advantage plans to switch to a different plan or switch to original Medicare and Part D. They can make one change during that Medicare Advantage open enrollment period. Folks on original Medicare don't have access to this. You can't use the Medicare Advantage open enrollment period to move from original Medicare into Medicare Advantage, but it's a nice opportunity for people who are in a Medicare Advantage plan. Maybe they picked something during open enrollment, it started effective January 1st, and suddenly they realize, my doctor's not in network, or this drug that I thought was covered actually isn't, or maybe they didn't make a change during fall open enrollment. They didn't pay attention to the changes that happened with their plan, and then get to January and realize, this plan no longer works for me. So it's a nice opportunity for folks who are in a Medicare Advantage plan to switch to a different plan if they need to. We also wanted to remind folks about the special enrollment period for dual eligibles and people with extra help. So folks who are dual eligible for both Medicare and Medicaid, or are enrolled in the Extra Help with Prescription Drug program, have an opportunity to change their coverage once per quarter during the first 3 quarters of the year through the special enrollment period. And then after September 30th, if they want to make any changes, they can just make a change during the fall open enrollment period that will be effective January 1st. But during the first 3 quarters of the year, if they make a change during one of those quarters, it's effective the first of the following month. And there's lots of other special enrollment periods. We provided a link to some more information about other special enrollment period in the materials. For example, if you move, or you become eligible for Medicaid, or lose Medicaid, or lose other creditable coverage, you get a special enrollment period to change your Medicare coverage. So just briefly, as I mentioned at the beginning, our focus at the Health Law Project is really working with low-income Medicare beneficiaries. So Medigaps often don't apply to those folks, but I think it's worth knowing a little bit about them. So Medigaps are Medicare supplemental insurance policies sold by private companies. This is supplemental insurance that works with original Medicare only. And basically it fills in the gaps of Medicare. So I talked earlier about how with Medicare Part B, for example, if you have original Medicare, Medicare covers 80% of a doctor's visit. If someone is also enrolled in a Medigap plan, that can fill in that gap that 20% coinsurance to help cover that. The best time to join a Medigap is when you first get Medicare. So when someone first becomes eligible for Medicare, they get a Medigap open enrollment period that lasts for 6 months. During that time, plans can't refuse to sell you a policy, and they can't charge you more based on your health status. So that is really the best time to try to enroll in a Medigap plan. After that first Medigap open enrollment period ends, folks can still apply and seek to enroll in Medigap plans, and many folks are able to, but they are subject to medical underwriting. Plans can refuse to enroll you, and potentially charge you more. But Medigap plans are standardized. All plans with the same letter have the same coverage, but the costs differ by the insurer. So we've linked to some information about choosing a Medigap policy. So as I mentioned, there are strict rules about when people can get Medigap policies. That open enrollment for the first 6 months after someone first enrolls in Medicare Part B. There are some other times when people get a guaranteed issue right that gives them another bite at the apple at enrolling in a Medigap plan without medical underwriting. But we did want people to know that there is no guaranteed issue right tied to losing Medicaid. So right now, one of the things we're going to talk about a little bit is that during the COVID public health emergency, people who were on Medicaid when the public health emergency started, for the most part, have been able to maintain that coverage. So the county assistance offices have not been able to terminate people's Medicaid coverage in most situations. Because of that, there are probably many people who missed their Medigap open enrollment period. If they stayed on Medicaid, Medigap companies can't sell Medigap policies to people who are on Medicaid because it's duplicate coverage. Medicaid also works as supplemental coverage for Medicare. So there may be lots of folks who, when they eventually lose their Medicaid coverage, when the public health emergency ends, will find, oh, I'd really like to enroll in Medigap, but they may be able to, but they won't have that window to get into a policy without medical underwriting. If someone is enrolled in a Medigap and then becomes Medicaid eligible, they don't really need to maintain that Medigap plan. Like I said, Medicaid also works as supplemental coverage, but they have a right to suspend their Medigap for up to 24 months. So we included information about how to do that. Maybe someone just became Medicaid eligible. They're not sure. I feel a little uncomfortable about just dropping my Medigap since I don't know if I'll be able to get back into one. They can suspend the plan so that they're not paying premiums for up to 24 months and kind of see how things go. Okay. So we'll stop there briefly to take questions.
All right, thanks, Katie. Yeah, so a couple questions have come in. And I guess just for folks that might have joined late, I will repost the PowerPoint and the links to some of the handouts a little bit later in the presentation, but hopefully most folks have seen those in the chat. So the first question, Katie, is can you speak to the enrollment process for Medicare Advantage plans? We encounter many patients that did not know they enrolled, and as you know, it is quite difficult to undo. Not specifics to the plan, but just generally how people enroll in Medicare Advantage plans, and possibly how people might get enrolled when they don't realize that they're enrolled in a Medicare Advantage plan.
Yeah, and I know Erin's going to talk a little bit about marketing abuses to watch out for, which is certainly a concern in this area. People can enroll in Medicare Advantage plans by going on Medicare.gov. We'll talk about this a little bit, but we encourage people to set up an account on Medicare.gov. You can make enrollment changes there. You can call 1-800-Medicare to enroll in a Medicare Advantage plan, or you can call a plan directly to enroll. And so sometimes I think what happens is people get in contact with a Medicare Advantage plan, sometimes because they wanted to, sometimes maybe they, there are many reasons somebody might be talking to a Medicare Advantage plan, maybe something shady is going on and they've contacted them. And talk, could talk to the Medicare Advantage plan and kind of be talked into enrolling. I think sometimes that happens, or they don't quite understand that's what they're doing. And I think Erin will talk a little bit about a special enrollment period that could be used to undo that. Hopefully that kind of answers the question.
Yeah, that's great, Katie. And this next question is maybe tied to this issue. So Aetna's calling people enrolled in their prescription drug plans and offering extra benefits like dental and vision. And then when this person called back, it seems like they're trying to shift people to an Advantage plan. And is that legal?
Well, yeah, maybe we'll get into that when we talk a little bit about marketing.
Yep. Okay. All right. And then this one, we're going to talk a little bit about extra help a little bit later on in the presentation, but does extra help reduce the deductibles that some plans charge? Is it the medical deductible, drug deductible? Do you just want to quickly take that and then we'll talk more about it?
Sure. So if somebody is eligible for full extra help, they get help with the deductible and the monthly premium up to a certain amount.
Yeah, and it's connected to Part D coverage.
Right.
It's connected to the drug coverage. Yeah.
Right.
Okay. And then you mentioned this, but just to reinforce, Medicaid can't, when people have Medicaid and Medicare, Medicaid acts like a supplemental policy and it covers, the Medicare cost sharing. Okay. And then just a comment in the chat that someone said that they found PA Medi to be very helpful in helping clients choose plans that best meet their needs, including Medigap plans. So I know we're going to talk about PA Medi at multiple times throughout the training and just kind of remind people that they're a resource during this open enrollment period and then otherwise through the year as people can take advantage of some of those other enrollment periods that Katy mentioned.
All right. Well, thank you for your questions. Someone asked if we're going to talk about Plan F. We're not going to get into the specifics of Medigaps. That's really not our area of expertise because, as I mentioned, we primarily work with low-income Medicare beneficiaries, but hopefully the link to the information we provided is helpful.
Okay. Great. Thank you, Katy. And Megan, I saw that I will repost the materials in the chat after I cover this next section. So hang in there and we'll get and then I'll email it out with the recording after the training. Okay, so now we're going to get into the Medicare updates for next year, which is probably why a lot of you joined us today. So the Medicare costs for next year have been announced, and this is much earlier than they have been in past years. Normally, the Part A and B costs don't get announced until later in the fall, but this year they were announced prior to the open enrollment period starting, which is great. So the Part A costs are going up a little bit, as noted on the slide here. The big highlight for this year is the Part B, as in bridges cost is going down. So the premium is going to reduce from right now in 2022, it's $170.10 a month. Next year in 2023, the standard Part B premium will be $164.90. And then the deductible is going down from $233 this year to $226 next year. So, so that's the big news for Part B costs. Just as a reminder, everybody, Katy mentioned this, everybody on Medicare has to pay the Part B premium. Some people with limited incomes and resources who qualify for the Medicare savings program that we're going to discuss a little bit later in the training have Medicaid cover that premium cost for them. And then other people with incomes that are over a certain threshold pay a higher premium for Part Bs. So different people on Medicare pay different amounts for their Part B premium, but everybody is responsible for paying the Part B premium for that coverage. Then the Part C and D costs vary plan to plan. So the Medicare Advantage premiums and deductibles and copays for services are going to differ plan to plan. As Katie mentioned, everybody in Medicare Advantage still has to pay that Part B premium, and then they may have an additional premium for that Medicare Advantage health and drug coverage. On the Part D drug side, again, the premiums, deductibles, and copays are going to vary plan by plan, and we're going to talk a little bit about that here on the next slide. So for the Part D costs, every year Medicare announces the cost structure for the standard drug benefit. And that's what is on this slide here. So for a standard drug plan next year, the premium is going to vary plan by plan. The national base beneficiary premium is $32.75. The deductible, if a plan charges one, can be up to $505. So people have to pay that before the drug coverage from the plan kicks in. Then people kick into the initial coverage period, where they might have to pay as much as 25% of their drug costs until their total drug cost reach a certain level of spending, which is $4,660 next year. Then they enter into the coverage gap phase of Part D. And again, people that have been around for a while might remember, a number of years ago when people who hit the coverage gap had to pay 100% of their drug costs. With the Affordable Care Act, that included provisions to close the coverage gap. So now the coverage gap is closed. It closed last year. And so there's still a coverage gap phase, but during that coverage gap phase, people are still can be charged up to 25% during that coverage gap phase as well. And then they're in that coverage gap phase until their out-of-pocket costs reach $7,400. And then they kick into what's called the catastrophic coverage phase, where they're going to pay the greater amount of 5% of the cost of their medication, or $4.15 for generic drugs and $10.35 for brand name drugs. So I guess to highlight this, again, the federal government sets out this standard drug benefit cost, but most plans don't follow this exactly. They can offer a benefit structure that's actuarially equivalent to the standard drug benefit. So a lot of the plans offer, different tiers of drugs, where lower cost drugs are on lower tiers with lower copays, higher cost drugs are on higher tiers with higher copays. Some plans don't have a deductible at all. Some plans only have a deductible applying to certain tiers of drugs. So there's a lot of different ways the Part D plans structure their benefit. And I guess because a lot of plans use tiered structures, people will still see an increase in drug costs when they hit that coverage gap. Because maybe I'm in a plan where I take a tier 3 drug and that costs me $35 for that copay. So I pay $35 when I get that drug while I'm in the initial coverage period. And then when I kick into the coverage gap, I'm going to pay 25% of the cost of that drug, which is probably going to be more than $35. So people are still seeing an increase when they hit the coverage gap. It's just they're now no longer responsible for paying 100% of the drug costs in that coverage gap. And we're going to talk about the extra help and how that helps people with limited income and resources be able to better afford Part D coverage. Okay, and the 2023 plan options were announced at the beginning of this month, end of September. So there are still a lot of options for Medicare beneficiaries in Pennsylvania, both in terms of standalone prescription plans and Medicare Advantage plans. So next year, there will be 26 standalone prescription drug plans that people who get their Medicare coverage through original Medicare or traditional Medicare can join. 7 of those standalone drug plans will be 0 premium for dual eligibles and others who qualify for the full subsidy. So there's a link to a handout of the list for next year. One thing to note, which is really nice, is that the 7 plans that are 0 premium this year in 2022 continue to be zero premium next year. So there's no change, there's no new plans coming in as zero premium plans, and there's no current zero premium plans that will no longer be zero premium next year. So there's stability in that list between this year and next year, which is great. On the Medicare Advantage plan side, like Katie mentioned, there's lots of choices. So some counties have up to 82 plan choices available, which just seems so overwhelming for people. Pike County has 29. That's the fewest amount of Medicare Advantage choices. And then Cumberland County is the highest with 82 plans. And I know I would not want to sift through that many plan choices. So I think choice is great. I think sometimes there's too much choice can be overwhelming to people. And again, special needs plans, we're going to talk a little bit about next, but these are Medicare Advantage plans that limit their enrollment to certain groups of people. The categories of special needs plans are people that live in institutions, so primarily nursing homes. There's a small number of plans that offer coverage to people with certain chronic conditions like cardiovascular disease or diabetes. And then there's special needs plans for dual eligibles, where you have to have some level of Medicaid to be able to join the plan. And these plans are also listed for anybody on Medicare that got their Medicare and You 2023 handbook mailed to them. There's a listing of all the plans available in the back of the book. Okay, so for the special needs plans for next year, again, the options, continue to be numerous for people in most counties. Again, you have to have Medicare and Medicaid to join. A handful of plans require people have full Medicaid coverage, so health benefits through Medicaid, in order to be able to join their special needs plans. But there continue to be a growing number of the special needs plans that will enroll partial dual eligibles, people that maybe only get the help with the Part B premium, or they don't have full Medicaid coverage, but they have some help with Medicare cost sharing. And we're going to talk a little bit about these different levels of dual eligibles later on in the presentation. One thing to keep in mind, the dual special needs plans only provide Medicare coverage. So there are efforts at the federal level and to some extent at the state level to kind of integrate coverage between Medicare and Medicaid, but we're not there yet. So someone who has a dual eligible who's enrolled in a Medicare dual special needs plan, that dual special needs plan is their Medicare coverage, and their Medicaid coverage is separate and it's secondary to that dual special needs plan. We're going to talk a little bit more about this all as we get in the dual section of the training. Again, since the dual special needs plans only enroll people that have some level of Medicaid, they all have the full extra help. So all of the dual special needs plans are zero premium. And every county next year has at least 3 dual special needs plans. Again, in the chat, you'll find a link to the listing by county of the special needs plans. And you'll see on that list, most counties have 10 to 14 plan options on the dual special needs plan side. So lots of, continued growth in that dual special needs market as well. One thing that I think we're still trying to gain a handle on is you'll see from the list, some of these plans are called dual access open. Some of these plans are PPOs as opposed to HMOs, and we're still kind of sorting through to figure out what that means for dual eligibles in terms of protections they might have and whatnot. So check back on our website or join our newsletter for updates as we kind of sort through all of that in the upcoming weeks. Okay, so let's talk about some enrollment changes that are going to start January 1st. There was a law passed that's known as the Benny's Act that included a number of provisions to simplify Medicare enrollment and minimize the gaps that people might experience between when they enroll and when the coverage takes effect. So one change is affecting the initial enrollment period. Katie mentioned when people turn 65, there's basically a 7-month window around them turning 65 where they can enroll in Medicare if they want to. And the coverage effective date depends on when in that 7-month window people make the enrollment choice and take the enrollment action. So the changes that start next year affect people that enroll in the last couple months of that 7-month window special enrollment period. So if people enroll 2 or 3 months after the month they turn 65, their coverage currently is delayed by 1 or 2 months. Next year, it's delayed by 2 or 3 months, depending on what month you join. And then, so starting next year, whether people join in the 5th, 6th, or 7th month, the Medicare coverage will start the 1st of the following month. And we'll go through a quick example here, but let's talk about the other enrollment changes coming that affect, that also streamline enrollment. So the other change, and this is where people ran into a lot of problems. So there's the general enrollment period where people that delayed enrolling in Part B or maybe even Part A, if they don't do it during their initial enrollment period, and if they didn't have coverage from a current employer, then they would have to wait until the general enrollment period every year to enroll in Medicare Part B typically, and sometimes Part A. So the general enrollment period runs January through March of every year. And under the current rules, people that enroll in this period, their coverage doesn't start until July. So that leaves people with a gap of many months of coverage before the coverage kicks in. So starting in January, when people enroll in the general enrollment period next year, their coverage will now start the month after they enroll. So it's not going to wait until July, it'll start the month after they enroll. And then we're waiting, there were some proposed rules issued in the past months that we're waiting to be finalized and waiting for the final rules to be issued. So again, on the Part B, as in Bridges or Boys side of Medicare, they're the only special enrollment period that exists right now related to enrollment is if people, again, are currently employed or their spouse is currently employed and they have coverage through that current employer. People in that situation can delay enrollment into Part B and enroll within an 8-month window of either stopping their employment or when the work coverage stops, depending on whatever happens earlier. So because there have been lots of problems with people maybe getting wrong or incomplete information from a health plan or their employer about their need to join Medicare when they turn 65, Medicare is considering establishing some additional special enrollment periods for Part B for certain conditions. So we're waiting to see what happens with that, but it's possible that there might be some additional Part B enrollment options starting as soon as next year. And these might be, to help people who are leaving incarceration be able to enroll in Medicare, people who had their Medicaid terminated, people that get wrong information from a health plan or employer, and then people that are impacted by an emergency or disaster. So none of that is finalized, but again, if things happen there, we'll include some updates in our newsletter. Let's just go through an example real quick about kind of how these enrollment periods are changing. So the first example is Kenny, who turned 65 in February of 2023. He enrolls in Medicare in May. So he enrolls kind of in the last 3 months of his Medicare initial enrollment period. So under the current rules, his Medicare would start in August, right? He enrolls in May, the coverage starts in August based on what month of the initial enrollment period he made the enrollment decision in. Next year, under the new rules, his coverage will start in June. So it'll start the first of the next month after he enrolls in the end of his initial enrollment period. And then the other example is Valerie. And Valerie turned 65 in early 2022. She didn't sign up for Medicare. So she has to wait for the general enrollment period, and she enrolls next February for Medicare Part B. And so her coverage is going to start March 1st under the new rules, instead of her having to wait until July 1st. which is the timeframe for the current roles. So that's just some quick examples about the enrollment streamline changes. Okay, another change that is starting as soon as January 1st next year. We're waiting for some more information to be issued about this provision as well. This was another change that was part of the Benny's Act that was passed at the end of 2021. So Medicare for people with end-stage renal disease kind of has a whole different set of rules compared to people that qualify for Medicare based on being 65 or being on Social Security disability for 2 years. And if somebody is only entitled to Medicare because of end-stage renal disease, and if they have a kidney transplant, then the Medicare entitlement ends 3 years after their successful transplant. So again, some people who have end-stage renal disease and have a kidney transplant, sometimes they become eligible for Medicare based on turning 65, based on qualifying for disability. We're not talking about that situation. We're talking about people that are only eligible for Medicare based on their end-stage renal disease status. And after they have a kidney transplant, the current rules are that the Medicare coverage ends 3 years after the successful transplant. When somebody has Medicare at the time of their transplant and Medicare covers the transplant, then their anti-rejection drugs to kind of help that transplant be successful are covered by the Medicare Part B benefit as opposed to the Part D drug benefit. So because the coverage for those anti-rejection meds typically ends 3 years after the successful transplant, Medicare is making a change allowing people that are under 65 who have had a successful transplant that was covered by Medicare. They can get or keep Medicare Part B coverage for those anti-rejection medications beyond 3 years. So that's the change. Let's talk a little bit about some of those details on the next slide. The one thing to note is that people that choose to do this option, Part B is only going to cover their anti-rejection medications. It's not going to cover any other Part B services. So it's not going to cover doctor's visits or lab work, any outpatient services that Part B covers, as Katie mentioned earlier in the training. The premium for this coverage will be $97.10 a month, and the deductible will be $226. So if somebody qualifies for the Medicare Savings Program that Katie's going to talk about in the next section, Medicaid will pay these costs. Otherwise, the individual that enrolls under this benefit will pay these costs for that coverage. So some of the details are still getting worked out, and we expect them to be more details to come when final rules are issued to implement these provisions, including kind of what other coverage people can and cannot have in order to be able to take advantage of this additional benefit through Medicare. So again, more to come on that, but just wanted to give people a highlight. On slide 6, we have a link to Medicare end-stage renal disease information. And if you click on that link, there's a little bit more information about this Part B immunosuppressant drug coverage for people that are interested. Okay, another big change for next year that is not going to impact so much the clients that we help at the Pennsylvania Health Law Project, who are mostly dual eligibles and get the extra help, but it's going to help people that are middle income, who maybe don't qualify for some of the programs that help with the prescription costs and are struggling to pay for their medications, including insulin. So next year, Part D drug plans will limit the copay for insulins that are on their formulary to no more than $35, which is really great. So that's going to start next year in January 1st for Part D covered insulins. Medicare Part B, as in Guay or Bridges, does cover insulin sometimes when it's administered through durable medical equipment, such as a non-disposable pump. The $35 limit for insulins for Part B covered drugs will start in July of 2023. So deductibles don't apply, neither Part B or Part D deductibles to insulins. And then plans can have lower copay. So a plan might, might decide to only charge $25 a month for covered insulins, which is fine, but the plans cannot charge more than $35 a month for covered insulins on their formulary next year. The challenge with this great change is that this change came about through the Inflation Reduction Act, and that was passed in the middle of August. The Medicare.gov plan finder information was already submitted prior to this change. So the plan finder for people that use Medicare.gov to compare their plan options, the insulin costs on the drug finder will not be correct for next year. So what Medicare recommends doing is doing a two-step comparison. First, include all of the drugs except for the insulin, see kind of what plan works in terms of the drug coverage and the cost for those other drugs. And then after you figure out the plan or plans that look good for you, then add in the insulins just to make sure that they're covered on that plan formulary. So it's going to be a little more of a challenge for folks that help people explore their Medicare options to do this two-step process, but that's how Medicare is advising people who take insulins to kind of work through the plan finder to find the best plan for you next year. The next slide will show, so even though the insulin costs aren't going to be, they're going to show up as likely more than $35 on the plan finder. When somebody enters an insulin into their drug list on the plan finder, Katy, sorry, can you go to the next slide? There will be a pop-up that just indicates that starting next year, there will be a $35 cap. The plans are all supposed to be instructing people about the $35 cost cap on covered insulins when their member services reps talk to people. At the pharmacy, the claim systems are all supposed to be set up so that when a pharmacy bills a Part D plan for a covered insulin, it's going to come back with a $35 copay. So there will be this pop-up, but the drug prices are not going to be reflected on the drug comparison tool. All right, I have a couple more slides and then we're going to stop for questions. The next slide about the plan finder, just to remind folks, this changed in the last couple years, but on the plan finder, people can do a general search and not have an account set up, not enter personal information. But the best way to get kind of personalized results or kind of see someone's personal information is to create an account on Medicare.gov for that plan finder. You don't need an email address to do that, but it does allow you to see kind of what your current coverage is if you are someone enrolled in Medicare already, or if you're helping somebody, it allows you to see what their coverage is. It allows people to save drug and pharmacy lists that can be updated rather than entering that information every time you go into the plan finder tool. And then it allows people to see their level of extra help. And then this year there will be enrollment request notifications sent to people in the message center. So when I help my dad, possibly change his plan for next year, we'll get a notice in his Medicare.gov account that will just confirm the enrollment change and provide some additional information there, which will be nice to get a follow-up confirmation in the message center. If people have an account for Medicare.gov, there is a personalized summary page that they'll get. It'll say hello, whatever the first name of the beneficiary is. It's going to have, their 2022 health or drug plan information if they're in one. It will show what the next year's plan will be if they don't make a change. It will show someone's extra help status, whether they have it or not, for this year and next year. It'll kind of show pharmacies that they've selected before. And again, it'll show if a pharmacy's in network or if one is preferred. Because for people that don't have extra help, preferred in-network pharmacies typically offer the lowest drug prices for people. And then there's, the drug list that will save their list of drugs that they've entered or that there's been claims data for, and then people can easily edit these things by just clicking that Edit My Pharmacies button at the bottom of the drug list. There's an Edit My Drugs button that will show up. Okay, just a couple more updates. Medicare is moving towards covering certain colorectal cancer screening tests at 100% by 2030. So next year, Medicare will cover 85% of the cost of certain colorectal cancer screening tests, and then coverage is going to increase in future years. But next year, Medicare covers 85%. Someone in original Medicare would be responsible for 15% if they don't have any other coverage. And then the other change that starts next year is that there's improved coverage of adult vaccines. So the big one is the shingles vaccine, Shingrix. There'll be no cost sharing if it's on the Part D formulary. And then other vaccines that are recommended by the Advisory Committee on Immunization Practices could be covered with no cost sharing. So this is another change that was part of the Inflation Reduction Act. Prior to that act passing, plans were encouraged to offer $0 or low cost sharing for vaccines, but now it's mandatory. And again, it's for Part D vaccines on the Part D plans formulary. Just keep in mind the flu shots, the COVID vaccines are all covered by Part B, as in bridges. Okay, and just some changes to look forward to in future years. There's going to be lower cost sharing on the Part D drug benefits starting next year. Starting in 2025, there's going to be a $2,000 out-of-pocket cap for people in Medicare Part D drug coverage. And then starting in 2026, Medicare will negotiate prices for certain high-cost drugs. They're going to start with 10 drugs that will be announced in September of 2023. So more to come, and we'll of course talk about these changes in future Medicare webinars, but just to give you a highlight about some things coming. And then the last slide deals with just the marketing, just reminding people about some marketing protections and what to do in the event that there's some problematic marketing or enrollment that occurs. And we talked a little bit about this with some of the questions, but Medicare does have marketing and communication rules that outline what plans and agents and brokers can do, as well as what they can't do when they're communicating with Medicare beneficiaries. So there's a link to kind of more consumer-friendly information, as well as more technical information for the lawyers on the call or other advocates that want to dig down into the weeds. The federal government, Katy mentioned the TV commercials that I think we've all probably seen, promising a lot of extra benefits, which might only be available in certain areas of the country. Some of the commercials with some prominent celebrities promise, help with the Part B premium, which isn't necessarily available. People again get calls or get get in touch with brokers and agents that maybe don't give them complete or can give them wrong or misleading information, leading them to enroll in a plan that's really not going to work for them. So the federal government is concerned about some of the problems that have been raised, like PMED raised a bunch of problems. We hear about problems where people, get tucked into signing up for a plan or feel pressured to sign up for a plan and then find out that that plan doesn't cover their doctors or doesn't cover their meds. And there are resources. People can reach out to PHLP if they have that experience for help trying to undo that. People can contact the Senior Medicare Patrol that investigates and deals with fraud in the Medicare system. People can call 1-800-Medicare. There is a special enrollment period for these marketing violations. So if somebody felt pressured to enroll in a plan or signed a paper not realizing that that paper was going to get them enrolled into a plan, or if they were flat out told that the plan was going to cover their doctors and it turns out they don't, then they can call 1-800-Medicare to request to change the plan based on the special enrollment period for these marketing violations. So just to kind of real quick address some of the questions that came up. Right now, insurance companies can call people that are enrolled in a different line of business. So if somebody's in a community health choices plan, then that insurance company could outreach to that person to talk about the Medicare dual special needs plan that the insurance company offers. If somebody's in a prescription drug plan through an insurance company, those folks could be outreached to, and they could, the person that's doing that outreach could talk about other Medicare Advantage products that they offer. So that is allowed under the current rules. But again, people cannot pressure people into joining. People cannot make it seem like it's a requirement to join those other plans. They can't call people out of the blue. They can't call people that aren't members of another insurance product they offer. They can't show up at someone's door uninvited. So there are some protections, and I think, we've definitely heard stories about people violating those rules that are in place. But again, there is that special enrollment period that people can take advantage of to get out of a plan that they joined either unknowingly or under the pretenses that the plan would work for them, and it doesn't. So that was a lot of information. I'm going to stop, and I think that there are questions that have come through before we move on here.
Yes, we do have some questions. Thank you for all that information, Erin. First, someone put in the Q&A that just a reminder that for the standard Part D benefit, the maximum deductible is the $505 that you mentioned. Some and many plans have lower deductibles, so thank you for noting that.
Yep.
Okay, and then we have a question about, I think this goes back to the Part D standard drug benefit also. How do drug costs go up when you hit the coverage gap, when you pay 25% in the initial coverage period and still pay 25% in the coverage gap?
Yeah. That's a good question. And again, it primarily relates to the plans that do tiering copay. So they're not charging 25% during that initial coverage period. They're charging copays based on what tier that drug is on. So that's where, again, somebody might have a set copay for a drug during the initial coverage period. And then when they kick into the catastrophic coverage, they're being charged for 25% of the drug cost. And that's where the costs go up. So if somebody's in a plan that structures their benefits like that standard benefit where they charge 25% during the initial coverage period, there wouldn't be any adjustment in the donut hole or coverage gap. But most plans don't follow that exactly, especially during the initial coverage period.
Okay, so good reminder to look at how your Part D plan works. All right, and I think this person was just confirming, for the insulin coverage, the $35 copay applies to insulins on the formulary in January and to DME products in July, correct?
Right, so any insulin that's not taken through kind of permanent durable medical equipment is covered by Part D drug coverage. So any covered insulin on the Part D formulary, $35 starts January. If somebody takes insulin through a non-disposable pump, then that insulin is typically covered through Part B, and then that $35 cap would start in July. Most insulins are covered through Part D as a drug.
Okay. And then there's a question about if someone is enrolled in a Medicare Advantage plan versus a prescription drug plan, will they have to cover the shingles vaccine at no cost also?
Yes, any Part D coverage, whether it's a standalone drug plan or a Medicare Advantage plan, if it's on that whatever plan's Part D formulary, then it has to be covered at zero copay.
Thank you. And then we have a note from a PA Medi counselor that the plan finder is not working well. Some days it will not allow setting up accounts. Some days it will not let people in with their username and passwords. Sometimes it says no such zip code or no plans in this area. So, good luck to you PA Medi counselors and to Medicare beneficiaries as you're trying to deal with this. Luckily, we've got, until December for the open enrollment period, but thank you for sharing that information. Another question, is there a fear that Medicare will just change their formulary for insulins to continue to change higher costs?
I'm not sure, is the person, I guess if the person that asked that maybe can provide a little more information. I don't know if the concern is that they would take insulins off the formulary. I don't know that that would happen. I hope that that's not going to happen. And when there are changes to the formulary, there has to be notification provided, and people can have their doctor request a formulary exception as well to get approval for that medication, even if it's not on the formulary based on your situation. Maybe you can't take another formulary medication because the side effects or other medication you're.
Okay, and she chatted in that that's what she was wondering because formularies change so frequently. So thanks for that additional information. Okay, someone asked if a podcast of this presentation will be made available. We will be sending out a recording after the presentation. Thank you for asking that. It'll be on YouTube. There'll be a YouTube link to it. And how can participants determine out-of-pocket mental health costs and providers? I think that's what this question is asking.
Yeah, so that's a good question. I mean, I think if they have Medicare, if they have original Medicare, right? Medicare, after you meet that deductible, Medicare pays 80% of a covered service and the beneficiary pays 20% if they don't have any other insurance. On the Medicare Advantage side, it's worth checking out the summary of benefits. It's worth looking through the evidence of coverage document that people get every year. There might be information on people's websites, and people should be able to call and talk to a member services rep who could clarify what the expected out-of-pocket costs are for different mental health services that the plan covers next year.
Okay.
And I don't know, a PA Medi rep can maybe chat in. There's some additional information on the Medicare Plan Finder about some other costs for other benefits for Medicare Advantage, but I don't know if mental health is included in that.
Someone asked, what if a pharmacy won't run the insulin through Part B, as in boy?
Yeah, so, and there's probably not an easy answer here. So again, most insulins are going to be covered through Part D, as in drug. If Part D isn't covering it, saying it's a Part B covered insulin because of how the person takes that insulin, I would try talking to a supervisor, maybe calling back and trying to talk to somebody else. If you're in a prescription drug plan or a Medicare Advantage plan, possibly reaching out to those plans to let them know of the problem, and hopefully they would contact the pharmacy to get the problem corrected.
Okay. And then there was just one more comment. Because of future caps, some premiums and drug prices are very high this year. I think this is related to prescription drug costs. So just a reminder to be sure to check GoodRx for the best price. Prices may be even lower if paying cash. So that's really for folks who don't have extra help, but that's a good reminder. Thank you. All right, thank you, Erin.
All right, thanks for all your good questions. I'll turn it back to Katy.
We are always happy when people are engaged and we're not putting you all to sleep, because we know this is a lot of technical information. So we do want to go over the programs that help with Medicare costs for folks who have low income and resources. So there's 3 programs that I'm going to talk a little bit about. The Medicare Savings Program, which is also called the Buy-in Program in Pennsylvania. This program primarily helps people with their Medicare Part B premium, B as in boy. Although I like Erin keeps saying B as in bridges. That's perfect for us here in Pittsburgh. And then we'll talk a little bit about the Extra Help and the PACE and PACEnet programs, which are both there to help with prescription drug costs. So I think, and we provided links in the materials. We have fact sheets on our website and also videos on our website about both the Medicare Savings Program and the Extra Help Program, and linked to the website where people can get more information about PACE and PACEnet. So Medicare is great coverage, but as you've heard for the past hour, it can be very expensive. And so we thought it was just worth highlighting for some context how many Medicare beneficiaries have low income. You can see from this graphic that in Pennsylvania in 2019, between 20 and 22% of Medicare beneficiaries had income below 200% of the federal poverty level. So these programs that we're going to talk about are really important for folks. People may be eligible for these programs, but are not aware that they're eligible. And these programs can really help people save money. And we know that Medicare also highlights these programs during the open enrollment period. Just as a reminder, these programs that we're going to talk about, the PA Medi program does help folks apply for all of them. We also know that the Medicare Savings Program and Extra Help benefits are underutilized. These are national numbers, but there are a lot of folks getting benefits through these programs, but there's also a lot of folks who are potentially eligible but are not enrolled. So we encourage advocates to ask questions if they're working with Medicare beneficiaries. Are they getting help with their Part B premium? Are they getting help with their prescription drug costs, to see and screen folks to see if they might be eligible? All right, so let's talk first about the Medicare Savings Program. The Medicare Savings Program is a Medicaid program, so it's run through the Pennsylvania Department of Human Services, and it primarily helps people with their Medicare Part B premium. For folks with the very lowest income and resources, they may also get help with their Medicare deductibles and copays, and also help with any Medicare Part A premium they have. So I think I may not have mentioned this earlier, but most people get Medicare Part A for free. But there are some folks who don't. You get Medicare Part A for free based on your own work record, if you have enough quarters of coverage, or if your spouse has enough quarters of coverage, or for some disabled adult children, if their parent has enough quarters of coverage. But there are folks, for example, folks on SSI benefits who don't have those quarters of coverage and don't qualify for Medicare Part A for free, and they can potentially get help through the Medicare Savings Program. The other benefit of this program is the Medicare Savings Program can also help people who qualify enroll in Part B without a late enrollment penalty. So we heard there's a monthly premium for Medicare Part B. You can't be forced to enroll. And so sometimes people don't enroll in Medicare Part B when they're first eligible because they feel like they can't afford that Part B premium. But if you delay enrolling in Part B and then realize down the road, a couple years later, maybe, several years later, sometimes we get calls like this from people, when you go to enroll, you discover that you're going to have a late enrollment penalty. So for every 12 months that you don't have Part B coverage when you could have been enrolled, a 10% penalty gets tacked on. And these penalties last for life if you're over 65. If you're under 65, the penalties reset when you turn 65. But the Medicare Savings Program is an excellent way to eliminate that penalty. If someone's eligible for this program, they can get enrolled in Part B. They don't have to wait for the general enrollment period, and any late enrollment penalty is eliminated. I did want to highlight that you do have to qualify separately for this program. So not everyone who's eligible for Medicaid gets help with their Part B premium. You do have to qualify separately. There are particular income and asset limits for this program that you have to meet. So we do work with lots of folks who have Medicaid, maybe through the MOD program or through the waiver program. They have a higher income. They do not necessarily also qualify for help with their Medicare Part B premium. So I think we've made this clear, but getting enrolled in a Medicare savings program can be a huge help. It gets people more money back in their Social Security check that they can use for food, housing, other costs. We know that lots of people don't know that they might qualify for this program. They might need help applying. One of the nice things about Medicaid programs is that you can apply at any time. There aren't particular times of the year that you can apply for a Medicaid program. So anyone can apply for this program at any time. Sometimes we know people have been denied in the past, but their situation may have changed. Maybe they had a spouse who passed away, they've stopped working, they've spent down their savings, and they might have been rejected in the past, but now they would qualify, but they haven't thought to reapply. So worth screening folks to make sure they're getting this help if they're eligible. Also, I think as has been mentioned previously, if you get help through the Medicare Savings Program, it automatically gets you help into the extra help program so that you get full extra help with your prescription drug costs. So these are the income and resource limits for the Medicare Savings Program in 2022. The income and resource limits for 2023 haven't come out yet. You know, I'm sure we'll put something out when they do, but these are the income limits for this program currently. So in order to qualify, you do need to have Medicare Part B or be eligible for it, and you have to meet these income and resource guidelines. If you're treated as a single person, if you are single, or if you do not live with your spouse. So if some folks are still married but don't live with their spouse, they would be subject to the single income limit. The monthly income limits we've listed here correspond with 135% of the federal poverty level. So this is the upper income limit to qualify for this program. There are 3 tiers to the Medicare Savings Program. I'm not going to get into a lot of detail about that just because of time constraints, but you'll see if you look at the materials we've shared, more information about those 3 tiers. Most people who get help through this program just get help with their Part B premium, but folks under 100% of the federal poverty level who meet these resource limits can get help with their Medicare cost sharing also. Those folks are referred to as qualified Medicare beneficiaries or QMBs. And being a QMB also comes with some other protections that are beneficial. But people don't have to choose what category to apply for. You just apply for the Medicare Savings Program. That piece gets worked out on the county assistance office end. So if you are applying for the Medicare Savings Program, there is a paper application. If you want to, you can apply for the Medicare Savings Program online by just doing the full Compass application. If you do that, we would recommend making a note that you're applying for the Medicare Savings Program. Sometimes people know they don't qualify for Medicaid. They only want to apply for the Medicare Savings Program. That's the benefit they qualify for. In their case, we generally recommend doing the paper form just because it's shorter. You do have to submit verification documentation to the county assistance office. You know, proof of your income, resources, things like that, your ID, all that good stuff. You do have to submit that information to the county assistance office. If you have submitted your application, you can call the customer service center to follow up on it just to make sure that it's been received and it's in processing. You can apply at any time, and you'll get a written decision about your application within 30 to 45 days. If you're denied for the program, you can appeal. And one more thing, you can get, in some cases, coverage up to 3 months retroactive. It kind of depends on what time in the year you're applying and what category of the Medicare Savings Program you fall into, but there is the possibility of getting a little bit of retroactive coverage too. We just wanted to mention briefly issues we've seen with the Medicare Part A buy-in. So this is, as I mentioned, only folks who have income below 100% of the federal poverty level are eligible for the Medicare Part A buy-in. But we're highlighting because we've seen a lot of problems with people not being enrolled in the Part A buy-in when they should be. Sometimes we'll talk to someone on SSI. They've been enrolled in the Part B buy-in. They're getting help with their Medicare Part B premium, but they weren't enrolled in the Part A buy-in. So they don't have Medicare Part A. If you don't If you're not eligible for free Part A and you're not paying for it, you're just not enrolled, and then you don't have that coverage. So we have been reaching out to the county assistance offices to ask them to review and enroll someone in Medicare Part A buy-in if they're eligible. We've done some advocacy with the state around this. There was a recent data sweep that the Department of Human Services did just last week, or just in the last 10 days, I think. It was October 17th. They were doing a data sweep to catch people who should have been enrolled in the Part A buy-in and weren't. And then anyone that they caught in that sweep, they indicated they would be processing them for the Medicare Part A buy-in. So if that goes through, the client should get a new Medicare card in the mail showing that they have their Part A and Part B enrollment date. They should get a letter from the county assistance office. So we are hoping that this will kind of correct this problem. But certainly feel free to refer folks to our office if they're eligible for the Part A buy-in and not getting it. We're happy to outreach to the county assistance office or help other advocates do that work. And, I think it's worth a reminder that if somebody has the income and resources that are low enough that they qualify for full Medicaid, even if they don't have Medicare Part A, they still have complete coverage. If they were to go to the hospital, they had a hospitalization, Medicaid would cover that. They just don't have Medicare to cover that, and that's fine. They still have complete coverage, but Medicaid is supposed to be the payer of last resort. You have to have both Medicare Part A and B to enroll in a Medicare Advantage plan. A lot of folks would like to enroll in a Medicare Advantage plan or a dual special needs plan, and they should be able to access those options. So I think it's worth helping people get this if they are eligible for it. All right. So why don't we pause there briefly just to see if there's any questions about the Medicare savings programs.
All right, Katie. Yeah, one question is, do adult children living in the household count toward the income and asset limits?
No.
Right, so children over the age of 21 don't.
Right.
Yeah, and if somebody has, oh, go ahead.
Oh yeah, sorry, Erin. If somebody does have kids under the age of 21 living in their household, they should list them on their application. They have to list their income, and then the county assistance office will do the calculation on their end and say, okay, they will either count them as part of the household if that helps the person qualify, or they won't count them as part of the household if it does not help them qualify.
Okay, great. And then the other question is, what determines eligibility or auto assignment to community health choices for someone that does not receive HCBS? So, I mean, we can hold that question. I think that's more related to Medicaid eligibility, or you can answer it real quick.
Yeah, if someone is dual eligible for Medicare and Medicaid, they're going to go into a community health choices Medicaid plan. Generally, in most cases, community health choices are the Medicaid plans for dual eligibles and people in the waiver. So even if you're not in the waiver or aren't getting long-term care Medicaid, just by virtue of being a dual eligible Medicaid beneficiary, you would, in most cases, go into a community health choices plan. But people get to choose their plan. They're auto assigned, I think, at the beginning, but or if they don't make a choice, but you can change that. There's an opportunity to change that every month.
Yeah, and then someone asked, this was answered in the chat, but just to make sure everybody sees it, does Social Security disability income, the SSDI benefits, count as income for the Medicare savings program eligibility?
Yes, it does. Yeah, and we didn't get into, like, there are income disregards for the Medicare savings programs also. So, not all income counts toward the income limit I listed on that slide. If somebody's working, only about half of their income counts. If they're receiving Social Security disability or, other unearned income, all but $20 of that counts toward the income limit. There's more information about that in our Medicare Savings Program guide.
Okay, great. There's a follow-up question. I'm going to hold that to the duals till we talk about duals. So, yep, we're good to go.
Sounds good. Thank you.
Mhm.
All right. All right, so the Extra Help Program is a Medicare benefit. There are two levels of Extra Help, full and partial Extra Help, that we'll talk about a little bit, but the Extra Help Program is something that helps folks with their prescription drug costs. It lowers your premium, the annual deductible, and the copays people are paying for their medication. The other benefit, much like the Medicare Savings Program, if someone has a late enrollment penalty for Medicare Part D, they didn't enroll when they were first eligible and didn't have other creditable coverage, and so they have a Medicare Part D late enrollment penalty, enrolling in the Extra Help Program eliminates that late enrollment penalty, which is a big benefit. And folks apply through Social Security and the Center for Medicare and Medicaid Services oversee this program. And any level of Extra Help eliminates that late enrollment penalty, whether you're eligible for full or partial Extra Help. So just like with the Medicare Savings Program, Medicare is expensive, prescription drugs are expensive, and being enrolled in the Extra Help Program can really help people control those costs. It was created to help people with limited incomes and resources afford Part D. And so we want to make sure that everyone who's eligible gets enrolled. All right, so we did want to share the 2023 costs. If somebody has full Extra Help, they can get a premium subsidy in 2023 up to $41.08. And Erin mentioned earlier, there are 7 zero premium plans in Pennsylvania for 2023, the same ones that were around for 2022. If someone wants to choose one of those plans and they have full Extra Help, they will pay 0 premium. But folks can also choose a different prescription drug plan, and they can get help with the monthly premium if they have full Extra Help up to $41.08. If you have full Extra Help, you don't pay a deductible. You'll see that the amount you pay if you have partial Extra Help, it provides some level of help. It helps contain the deductible. It helps contain the amount that you pay, 15% coinsurance versus 25% in a standard drug plan. It just doesn't provide quite as much financial assistance. But I think the biggest benefit really is that your copays for your prescription drugs are limited if you're enrolled in full Extra Help. What your copays, the amount of copays you pay depends on your income. So if you have income below 100% of the federal poverty level, your copays are limited to $1.45 or $4.30 for a brand name. For most people whose income is above 100% of the federal poverty level, they're going to be paying about $4 for generic medications and around $10 for brand names. But for folks who are enrolled in a long-term care Medicaid program, either the waiver or if they're in a skilled nursing facility receiving Medicaid or in a life program, they would pay $0 for their copays. So you can see, since we added a column to show, what people pay if they have no Extra Help, that this can really be a huge benefit to folks. One of the nice things about Extra Help is if you get any Medicaid benefit, even if the only Medicaid benefit you get is help with the Part B premium, you automatically get full Extra Help. You don't have to apply. But if you're not getting any Medicaid benefit, you do need to apply. Social Security processes those applications, and you have to meet the income and resource limits for this program. So this is the income and resource limit for Extra Help in 2022. Again, the new limits for 2023 will come out later. But these are currently the income and resource limits to qualify for full extra help. One of the exciting changes that is coming out of the Inflation Reduction Act is expanded access to full extra help. So this change doesn't happen until 2024, but starting in 2024, the full extra help income limit will increase to 150% of the federal poverty level. Right now, it's 135% of the federal poverty level. These are the income and resource limits for partial extra help currently. As I mentioned, with this change that happened through the Inflation Reduction Act, starting in 2024, there won't be a partial extra help category anymore. It'll, right now the income limit for partial extra help is that 135 to 150% of the poverty level window. Full extra help is just the income limit will be raised to 150% of the federal poverty level. If you qualify for extra help, you get full extra help starting in 2024. So we will certainly look forward to that. So with the extra help program, you can apply at any time. You don't have to have Medicare Part D to apply. You just have to be eligible for it. If you are, reminder that if you're getting any Medicaid benefit, you don't need to do an application. But if you do need to do an application, you apply through Social Security. We recommend applying online. That is the easiest way to do it. You can get a paper application from the Social Security Administration, but you can't use a photocopy, so you have to get an original application in order to apply on paper. However you apply, PA Medi can help you with that application. Social Security reviews the applications, decides whether you qualify, and sends you a notice in the mail letting you know if you qualify. If you're approved, that information goes to your prescription drug plan, so your costs go down automatically. You don't have to do anything on your end to notify your prescription drug coverage. The nice thing about applying for extra help is that it's, typically you don't have to supply any verification documents. Federal government has a lot of information already about our income and resources, right? We do our taxes, they've got all that information. If they need additional information, they will reach out and ask for it. So just a reminder about this, if you're getting any Medicaid benefit, as I've said repeatedly, you automatically get full extra help, but sometimes people get confused about how long that extra help lasts. So if you have a Medicaid benefit, you are automatically enrolled in extra help, and that benefit automatically lasts to the end of the year. So if someone were to lose their Medicaid at some point in the year, sometimes they worry, am I also going to lose my extra help benefit? And when you will lose your extra help depends on when you lose your Medicaid. So the extra help program deems someone as eligible, checks someone's eligibility once a year in July. When they do that deeming, they deem you for the rest of the calendar year and the next year. So if you're on Medicaid and you were to lose your Medicaid in February, for example, you would still have your extra help for all of 2023. Because the extra help deeming happens in July, if someone loses their Medicaid benefits in December of 2023, they will have already been qualified for extra help for all of 2024. So I know that is a little confusing. As I'm saying this out loud, I'm thinking I'd not necessarily explain it super well, but I think the big takeaway is that people don't lose their extra help status automatically when they lose Medicaid. This isn't really an issue right now. During the public health emergency, people have their Medicaid covered, have had continuous Medicaid coverage. But we know when the public health emergency eventually ends, there are going to be people who lose their Medicaid coverage, and they'll be concerned about this. But because of the public health emergency and just the point we're in the year, anyone who has any Medicaid benefit right now is automatically going to have it for all of 2023, period. If someone isn't sure if they have extra help or what their extra help status is, they can check that on medicare.gov if they have an account, or you can call 1-800-Medicare. So this is also the time of year that people who have extra help are potentially getting mailings. And CMS sends several mailings each fall related to extra help. People get notices if their automatic extra help is going to end this year, if their copay amounts are going to change. For example, they're moving to partial extra help because of a change in their income or resources. And a certain number of people get polled each year to check whether they're still eligible for extra help. These are folks who have applied for extra help, not folks who have a Medicaid benefit and are automatically getting it. But a certain number of people are reviewed each year to see if they still qualify. If you get that notice, you do have to send in that information to make sure you're still eligible. Otherwise, your extra help will end at the end of the year. So pay attention to those mailings about extra help. Finally, we wanted to mention the PACE and PACEnet program. This is a prescription drug program for older adults with limited incomes in Pennsylvania. It's called the PACE and PACEnet program. This is a program that's available to folks who do not have full Medicaid. So you can get PACE and PACEnet benefits if you just get help with your Part B premium, or if you're getting help through the Medicare savings program. So people who have full Medicaid do not qualify for these programs. But it's super simple to apply for PACE and PACEnet. Resources aren't counted. They only look at your income. And so it's a really good option for people who may have low income but have a lot of assets. Maybe they've got retirement accounts, they have savings, and so their savings puts them over the extra help limit. This is another way that they can get help with their prescription drug costs. Just this year, the income limit for PACEnet went up $6,000 in February. The expectation was with the increase in the income limit, an additional 100,000 people would be eligible for help. So this is a pretty generous program. It's easy to apply. We just wanted to basically remind folks about this. So we can take questions now.
Yep, there were a couple, Katie. Can you just say again what the income limit is for full extra help versus partial extra help? Maybe just the percentage of poverty difference between the full and extra.
Yeah, full extra help is 135% of the federal poverty level. Partial extra help is 150% of the federal poverty level.
Okay, and can you just go back to the slides real quick so people can see the resource limits? It's like the resource limits for full extra help as well as partial extra help.
Yeah, so this is for full extra help. So around 10,000 or 15,000 if you're married, and then partial extra help, 15,000 if you're single, 30,000 if you're married. And in our materials, we have, the monthly income and resource guides for Medicaid and other programs. That also has the extra help income and resource limits.
Okay, and then how long does it take after applying for Medicare extra help to receive an eligibility decision?
It doesn't take too long. I don't think there's a specific time frame for extra help the way there is for Medicare savings programs, but they typically do review those applications fairly quickly.
Okay, and then is the income limit for MSP still 120% of the federal poverty level for people on mod or waiver?
Yes. Yes. Thank you for asking that, Angela, because I should have mentioned that. Yeah, if somebody gets another Medicaid benefit, they're only eligible for the Medicare savings program if their income is below 120% of the federal poverty level. Like I said, they can't just make it simple. Like there's tiers with different rules, but I think our takeaway is generally, if you're not getting this help and you think you might potentially be eligible, you should apply. The same thing is true with the income limits for the income and resource limits for extra help, just like Medicare savings program. Not all income counts, not all resources count. So if you think somebody's on the line, it's worth, checking their eligibility or having them apply.
Okay, great.
And I see somebody asked if you're in an ODP waiver, do you qualify for a CHC plan? And the answer is no. Maybe you were going to hold that to the dual eligibility section. Sorry, Erin.
Right, yeah, I'll address these next two.
Okay.
I'm gonna do dual eligibility in less than 5 minutes, so we leave time for the COVID unwinding, which is timely and important information. So I'm just gonna run through stuff on the dual side. For those of you who have attended our trainings before, we talk about dual eligibility every Medicare webinar, so we have lots of information on the slide. If we can still address questions about dual eligibility, and certainly reach out to Katy or I with more questions. Dual eligibility, people that are dual eligibles have Medicare and some level of Medicaid. They have really good coverage, but it can be really challenging kind of understanding the changes that happen when you first become a dual eligible, and also navigating the two systems of benefit. So just at a high level, Medicaid is also a really big health insurance program. It is administered by both the federal and state governments, and both federal and state funds cover the Medicaid program. We are at a record enrollment in Pennsylvania with 3.5 million Pennsylvanians covered by Medicaid. So that's 1 in 4 people, our neighbors, friends, family members, coworkers, people that we encounter when we're out and about in the community, to the extent that we're doing that still in the pandemic. So lots of folks rely on this important program. It can be somebody's only insurance, or it can be secondary coverage, or sometimes people's third coverage. And like Katy said, Medicaid's always the payer of last resort. So with dual eligibility, again, it's good coverage, but it's complicated. There's certain protections that apply to duals that don't apply to other Medicaid beneficiaries. And Medicaid, the dual eligibles, they're kind of a high need and high cost population. Not everybody who's a dual eligible fits into that, but somebody, but a lot of folks have a lot of needs or a lot of health problems. There are full duals and partial duals. So the full duals are people that have full health insurance coverage through Medicaid. These are people that qualify under the Healthy Horizons category, the Medical Assistance for Workers with Disabilities program, any of the waiver programs. People get full Medicaid, as well as the in-home services, people on SSI, and then people in nursing homes on Medicaid. All of those people that fall into those groups are full duals. Like Katy said, people may or may not get help with the Part B premium when they're on full Medicaid. It depends on whether they also qualify for that help. We've had some questions about this, but when you're on Medicaid, Medicaid decides what delivery system you get your coverage through. So people don't get to decide. So if they're a dual eligible, and if they're not receiving services through an ODP waiver, any of the waivers for intellectual disabilities or the adult autism waiver, if they're not getting intellectual disability based services, then they're going to go into CHC for their Medicaid. If a dual eligible has one of those waivers for people with intellectual disabilities or autism, or is in the OBRA waiver, or gets ID-based services, their Medicaid coverage will be through the fee-for-service system with the access card. And then there are a small number of dual eligibles that are under the age of 21, and those folks stay in health choices for their Medicaid coverage until they turn 21, but their drug coverage stops. So there's different delivery systems of Medicaid. Medicaid puts you in that, you don't decide. So if you want to leave CHC, you cannot leave CHC without losing Medicaid, if that's the delivery system that Medicaid put you in. Medicare is always someone's primary insurance. It's going to pay for most healthcare services people get. Duals have to have Part D prescription coverage because Medicaid stops covering most prescriptions. Billing protections apply. We have a couple slides on that I'm not going to cover today, but it's reference material. Then reach out if you have any problems with balanced billing on the Medicare Medicare side for somebody that has Medicare and full Medicaid coverage. Then Medicaid, full Medicaid will cover the Part A and B deductibles. Medicaid's coverage when people qualify for full benefits is broader than Medicare. You know, Medicaid covers dental, it covers eye exams, it covers some incontinence supplies. Their coverage criteria may be broader than Medicare's coverage criteria. So if somebody needs something like dental services and they have original Medicare, their only dental coverage is through Medicaid. And in that case, Medicaid will pay as the primary because someone doesn't have any other insurance for that service. Medicaid does cover certain over-the-counter medications. Medicare Part D does not cover over-the-counter medications. So these are certain vitamins, stool softeners, laxatives, some other over-the-counter medications. We have a link to a fact sheet in the PowerPoint for that. Medicaid does not pay second to Part D drug benefit. People have the extra help, they pay those copays. Medicaid does pay second to Medicare Part B, as in bridges. So if somebody takes insulin through a pump that's not disposable, that's going to go through Part B. Medicaid pays second for that. Diabetic testing supplies like test strips and lancets that people get at the pharmacy, Medicaid does cover second to that. So Katy talked about the dual eligibles and extra help, so I'm going to skip over that. Duals have the same plan choices as any other Medicare beneficiaries. So they can choose original Medicare with a standalone drug plan or a Medicare Advantage plan. And within that Medicare Advantage plan subset, they also have the added options of joining a special needs plan for dual eligibles. And again, if they join a plan that's zero premium with the full extra help, they're not going to have an additional Part D cost. But some duals can't find a zero premium plan that will cover their prescriptions. So some dual eligibles have a Part D plan where they do have a premium, even though they have full extra help. Let's just skip over the billing protections. Again, there's reference there. Some ideas for troubleshooting balance billing problems. Like Katy said, if somebody doesn't have Part A or B of Medicare and they have full Medicaid, Medicaid should cover that service that would otherwise be covered by Part A or Part B. But just know there's a lot of confusion about this. Sometimes the CHC plans say that they won't cover it if they don't have Part B. There might just be some extra hoops people have to jump through. But if somebody's having problems getting services when they don't have Medicare A or B and they have full Medicaid, please reach out to us at Health Law Project and we would help you through that. And here's just some resources if people are having trouble getting prescriptions after the new year or even for the rest of this year. There's links to some programs and some policies that have been in place and we've talked about in past webinars, but just as a reminder for some protections to help dual eligibles get prescriptions, especially at the start of the plan year for next year. Let's see if there's any other slide. I think that's it, right, before we move on to COVID.
Yeah, I think that's it. And okay.
Why don't you want to just go through the COVID stuff and then we'll take questions?
Yes. Yeah.
Okay.
I think that's a good idea. So just, we all know we've been in a public health emergency for a long time. The public health emergency was renewed again just recently in mid-October. The federal government has pledged to give states 60 days advance notice of when the public health emergency will end. It could be extended again, but there's kind of an expectation that this might be it. So we should hear soon whether we can expect the public health emergency to end in mid-January or if it will be extended again. During the public health emergency, Medicare has covered 100% of the costs of COVID vaccines and treatment. Once the public health emergency ends, this particular protection will end also, and then it will just go back to however Medicare would typically cover COVID vaccine and treatment. There's some other Medicare flexibilities that have been in place during the public health emergency. Those will also end when the public health emergency ends. I think we wanted to talk a bit more about Medicaid protections during the COVID public health emergency. We've mentioned that folks have, for the most part, not been able to be terminated from Medicaid during the public health emergency. But we know that people with Medicare can have their Medicaid coverage reduced. So we did want to talk about that a little bit. The current continuous eligibility protections can all be found in this ops memo we've linked to in the materials from the Department of Human Services. It's been updated several times as things have changed a little bit as the public health emergency has progressed. But during the public health emergency, someone with Medicare, when they do their annual renewal, or if they're new to Medicare and the county assistance office is reviewing them, they can have their full Medicaid terminated if they are eligible for one of the Medicare savings programs. So we've certainly heard from a lot of folks who were confused about that. I know PA Medi has heard from a lot of folks who say, oh, I thought I couldn't lose my Medicaid during the public health emergency. This is really the biggest category that we've heard from, is folks who are eligible to be moved into a Medicare savings program can lose their full Medicaid and be put into a Medicare savings program only. That's only if they qualify for that Medicare savings program. Otherwise, people can lose their Medicaid if they move or die or ask for their Medicaid coverage to end. There's some other situations, but the Medicare beneficiaries having their Medicaid reduced is the one category we wanted to highlight. If the county assistance office is going to be changing someone's Medicaid, the level of Medicaid they get by reducing their benefits, for example, or terminating them in those very limited circumstances where that can happen, they do still have to send advance notice out to folks. The notice date has to be 15 days before the change takes effect, and people can appeal these decisions. You can reach out to our office if you want help determining, is this an appropriate change? And then we have gotten a lot of questions, people who became Medicaid or Medicare eligible and have been left on Medicaid because of the public health emergency, when typically their Medicaid eligibility would have ended. Some of those folks have wanted to enroll in dual special needs plans because they're full dual eligibles, and we've been in touch with the state about this. Some people left on Medicaid during the public health emergency, the way they're coded in the Medicaid system does not allow them to enroll in a dual special needs plan. The dual special needs plans have a list of Medicaid codes that they're allowed to accept. And we've had some back and forth with the state about this, but they've kind of held firm that there are some particular codes that people are in that don't allow them to enroll in dual special needs plans. If you don't know, you're working with someone who wants to enroll in a dual special needs plan, this seems pretty wonky now that I'm saying this out loud. So I don't know how often this comes up for folks who aren't PA Medi counselors or us. But you could call the customer service center at the Department of Human Services, find out someone's Medicaid code. We're happy to talk about this if needed. When the public health emergency does eventually end, there is going to be a hot mess, probably. So there are about 1 million people who have COVID flags, is the way the Department of Human Services is putting it. There's about 500,000 people who have been identified as likely no longer being eligible for Medicaid when the public health emergency ends, and another approximately 500,000 who have not completed renewals. So they don't really know if they're still eligible, if they've moved, who knows. So Pennsylvania plans to do a 6-month unwinding, which means when the public health emergency ends, all these folks that have been flagged by the Department of Human Services have to be reviewed before anything can happen to their Medicaid eligibility. So the county assistance offices will be doing renewals of eligibility with everyone on Medicaid eventually, but with all of these folks in particular, and determining if they're still eligible for benefits. They plan to do this over a 6-month period. And we know that the county assistance offices are understaffed. They do a really good job, but they're going to make mistakes dealing with this kind of volume. So we will be at the Health Law Project, putting out stuff in our newsletter. We'll be doing webinars when it's time for the public health emergency ends to help other advocates know how best to help people on Medicaid. But at this point, we certainly encourage people to make sure if they're getting Medicaid benefits that they have updated their address with the county assistance office so they don't miss things in the mail. If they need to, they can designate another person to also receive copies of notices they receive. If they have questions about their eligibility, they can call the customer service center. They can call the customer service center to update their address. They should also be able to do that on Compass. But when this all ends, if somebody is going to be losing their benefits, they have to get written notice that they can also appeal. And I think these were just a few more reminders, but I think we've really covered the important things. Just a reminder about sources of help. We've mentioned PA Pennsylvania State Health Insurance Program can provide free help for Medicare beneficiaries. People can call 1-800-Medicare to get, if they are not sure what their coverage is or want to make coverage changes. And we can help people who have questions about Medicaid eligibility or having trouble accessing Medicaid coverage or services. So I think we can, in our contact information, we hope you'll follow us at the Health Law Project, sign up for our newsletter. Our resource library has lots of good fact sheets. I know someone asked in the chat about MAUD. We have a fact sheet about MAUD. We have videos about MAUD, so that we have a lot of good information on our website. And folks can feel free to reach out to me or to Erin if you have follow-up questions or contact our helpline. So thank you for sticking through.
Yeah, thank you. And we'll stay on and take a couple more questions if they come in. There are 2 in the Q&A, Katie, if that's okay, we'll address those. And if anybody else has questions before hopping off, feel free to put them in. Is that okay?
Yeah.
Okay. So one is there a website that gives feedback on Medicare Advantage plans? For example, a site that gives no nonsense feedback.
I'm not sure about that. On the plan finder, there's information about the plan star rating, which
Right.
maybe could be helpful.
Right. That's the only place that I know of, the Medicare.gov website, that just gives star rating. I don't know of another comprehensive site that's going to have more straightforward feedback than that.
Right.
Okay, and then Danielle asked, do you know anything about the $100 card Aetna is sending out? What can it be used for?
I have not heard about that, but I know some of the plans. I wonder if it's an over-the-counter card. Do you know what it is, Erin?
I don't know for sure. That's my sense that it's probably an over-the-counter card. But I would maybe have the person that got it contact Aetna for clarification about what they can use that for. A lot of the Advantage plans seem to be offering like a quarterly over-the-counter benefit, right? That maybe they can use at a local pharmacy for over-the-counter medications or first aid supplies or other things. Or maybe other plans maybe have a catalog that people can use to order stuff from, like grab bars. There's some, they are all different. And then Joan from PA Medi said that some cards are for groceries or co-pays. So yeah, I think it differs plan by plan, and people should probably reach out to their plan to clarify what that card can and cannot be used for. Let's see. Lots of thank yous, which is very nice. Still confusing, which it is confusing still. My biggest challenge with being a dual eligible is handling billing issues and filing complaints. Okay, all right, yeah, that's an ongoing challenge, unfortunately. Are D-SNP plans ever a good idea? Every time a client has switched to one, it has made their life more complicated, it seems.
Yeah, I think everyone's situation is different, and that's why, certainly just because someone is dual eligible does not mean that a D-SNP is going to be their best option. There very attractive with all of their extra benefits. But you still have network issues, especially in rural areas where there might not be a lot of providers. Often if you're a dual eligible, having original Medicare might be the best option because it gives you access to any doctor who takes Medicare, and you have that Medicaid coverage for your supplemental secondary coverage. So I think for some people really like their dual special needs plan, but it's not going to be right for everyone.
Okay, yeah, and I guess I think some people that join maybe either help people in other states in addition to Pennsylvania. And so, the dual eligible information and the plan information is specific to Pennsylvania that we covered today. But there might be other resources, like every state has a state health insurance program that can help counsel people about Medicare choices in their state. And then you can check with a state's legal aid network that we're part of the Pennsylvania legal aid network. We're a specialty program. So there might be other legal aid resources in other states that can help dual eligibles.
Mm-hmm. Yeah. And we'll be sending out afterward, we'll be sending out all of the materials that, a copy of our PowerPoint and all the materials we put in the chat, along with a link to the recording.
Yep. Yeah. And then, yes, we talked a little bit about how Medicaid's coverage can be broader than Medicare's. Medicaid does cover some dental services, and it gives people the ability to enroll in the medical assistance transportation program. So there are some benefits that some of these extra benefits that Medicare Advantage plans offer are available to anybody with full Medicaid coverage.
Oh.
Okay, who are the best people to guide us older parents as we make decisions for our autistic daughter who is also on Medicare like us? Yeah, I think you could reach out to the Health Law Project. We'd be happy to talk to you a little bit about some choices. You can reach out to PA Medi to talk to them. There might be some other local resources, like the Centers for Independent Living might have people that can talk to folks about their plan choices. Katy, any other initial thoughts?
Yeah, and I don't know if what you're thinking about is, Achieva has a future planning project also for, I think it's kind of geared toward parents of adults with disabilities. That can be a good resource also.
Yeah, and I think some of this, that a lot of times people need it's helpful to talk through someone's specific situation, because the information we covered today is kind of general, but it always helps to talk through someone's specific information, especially because of how complicated and confusing these programs can be and how they work differently for different groups of dual eligibles. So certainly recommend talking to somebody. How does MA work for people who are duals who have Medicare Advantage plan that's not a dual special needs plan? Medicaid still is secondary to that Medicare Advantage plan. So it doesn't work, it shouldn't work any differently than if someone was in a dual special needs plan, right? Or original Medicare necessarily. Medicare, however you get it, is always going to be primary. Medicaid is always going to be secondary for most services. For services that are broader and not covered by Medicare or your Medicare Advantage plan, then Medicaid is your only payer for that. You might have to pay a little bit of a premium towards a regular Medicare Advantage plan, depending on how much extra help pays towards that particular plan's premium. Katy, I'm probably forgetting something else big. Anything to add to that?
I don't think so.
Okay. All right, well, thank you all for your great questions and for being so engaged for the 2+ hours during the presentation. It's always, Katy and I always enjoy talking about Medicare and dual eligibility, and we know it could probably go on for hours, more than it already has gone on. So thank you so much.